every single medical student is at least using ChatGPT to prep for cases, to help them form presentations when they're rounding. I would say when it comes to the more specific tools, and maybe the tools that some people are using to build applications like Claude Code, that is a more specific group of people. And that's the type of people that were working on this ebook. But the reason why we put together this ebook was to be able to reach those medical students that are really interested in learning more about how AI is impacting their medical specialty, but they just don't know where to start.
Welcome to How I Doctor, where we're bringing joy back to medicine. Today's guests are a little bit different from the nearly 90 folks I've had on the show so far. That's because they're still in med school. And they just wrote a field guide for AI that we at Off-Call published with MD+, a community of physician innovators and entrepreneurs. Emily Leventhal is a third-year MD PhD student at the Icahn School of Medicine at Mount Sinai with interests at the intersection of AI, genetics, and women's health. And Rishma Jeevan is a fourth year at Rush Medical College who, before starting med school, spent years inside of San Francisco health tech startups helping health systems actually implement the tools physicians are now being asked to use. Together, they co-led the creation of the Physician's Guide to AI, a practical ebook covering 9 specialties built by more than 40 physician authors from med schools across the country. It's the first resource of its kind written specifically for newly practicing physicians by the people who are going to inherit our current healthcare system. What I want to find out today is what this generation actually sees. Not the conference talk version, not the stuff that you might hear about online, but the stuff that they say in the hallways, what their classmates think, what resistance they're running into on rotations, and what they think doctors practicing are already using, and where we might be getting this wrong. I'll be back with Emily and Rishma after a quick word from our sponsors. Before we jump into the episode, I want to thank our sponsor, Evidently. Evidently is the clinical data intelligence platform built to help physicians harness the ocean of patient data they're drowning in every day. From chart summarization to AI-assisted note drafting and denial appeal support, Evidently makes sure the right data shows up at the right time. Physicians using Evidently report spending less time hunting through charts and more time focusing on patient care. That's why they've become a trusted partner to health systems looking to improve documentation, quality, and revenue sustainability. The company is led by providers and AI researchers that are dedicated to reducing documentation burden and helping clinicians practice at the top of their license. If you want to see what Evidently can do for your hospital or your practice, reach out today at www.evidently.com. Now, let's get into today's episode. Emily, Rishma, welcome to How I Doctor. Thank you for being here.
Thank you. We're so excited to be here.
Yeah, thank you so much for having us.
It's rare that I get to talk to 2 interviewees for the price of 1. And then the fact that you guys are in med school, I think, is fascinating. I think, Emily, you just finished your 3rd year of rotations, and you're about to start your PhD portion. And then, Rishma, you're in your 4th year as well. So you guys have been on the wards, been in the clinics. You are no longer just preclinical med students.
Yeah, that's right.
You are both in the thick of it, and you're still in your training. Your medical physician doctor brains are still being formed. What does that let you see that maybe somebody like me, who's been out of training for almost 20 years now, would miss?
We started medical school without the AI being easily accessible. ChatGPT wasn't really there yet. And now we're ending our med school training with a lot of it. We're going into the workforce with it. And so we've sort of seen that change happen right in front of our eyes, even during our clinical years. So it's been really nice to see what it means to be a student without it, to understand medicine and healthcare without it, while also understanding how our attendings are adapting to it, how our residents are adapting to it. What AI has done has added a layer where it's bi-directional learning. And so while I'm learning a lot of traditional medicine from them, we are sharing, what am I using? What are you using? How are we using it? And it really speaks to what being peers with your attendings and residents feels like, in addition to learning medicine and patient care. So this has been a really fun experience, I think, for a lot of us. And it's really a great way in which we're able to shape the understanding of not only our peers and future students, but also the workforce that we're entering.
Emily, what about you?
I would totally echo that sentiment about attendings and residents wanting to learn from medical students about AI. I think they appreciate that we are the younger generation that might be more used to adapting to these new technologies. So I would get questions all the time on my rotations when attendings would find out that my PhD was in AI and emerging technologies. They would ask me, okay, so what do you really think is going to impact the field? How are you using AI? And that was one of the starting points for the reason why we started this book, because we continued to hear those questions in the clinic.
I came into this thinking like, oh, I'm not going to have any sense of what you guys are going through. But now, like reflecting back and hearing you guys talk, I'm like, oh, I went through this myself. Like, I know what it's like to be on paper for charting and then to go to EHRs as well. Like, I was in a transition period 20 years ago where some of the charts were on paper and then other information was in the EHR. It was also like you guys said, like a transition time. Some of my rotations would be paper based and then other ones would switch to computers for almost everything. How do you guys see that transition? Like, what do you think the value is that you know the pre AI way to do things?
So I would say the biggest help of AI is really different in the preclinical years versus the clinical years. So maybe I didn't experience how being on a clinical rotation would be without AI, but I can tell you that it helped so much in my rotation. And I find that other students are really leveraging it in the same way to help their learnings. So I feel like in the past, before a big surgery the next day, you would have to manually find all the resources to learn about the case. You would go through the patient's chart, learn everything you can about the patient, try to read research articles where you can. And now we have this amazing tool that can synthesize all of that for us and act as a teacher, go back and forth, ask us questions that the attendings might ask us in the case the next day. And I think that other medical students haven't really had to be told to use it. Everyone is just naturally using these tools that are available to us.
Rishma, how are you using them?
If you come from a background of professionals who are in medicine from your family, you have imbibed a lot of information about the healthcare system and what it means to think like a physician. But we've had for quite a while now a more diverse student population, and many of them do not come from that background. And so we talk about the hidden curriculum, and that's something that has been a barrier, still continues to be a barrier, which AI can help mitigate quite a lot. What does pre-rounding even mean? I think I had peers that came in knowing exactly what that meant, or, oh, you have to create the list for surgery. I didn't know what that was, right? And I could look that up and get that context. And that also meant that when I am interacting with my residents and with my attendings, my questions are better than what's the first line therapy, right? They're now, why do you want to use this therapy instead of that based on your experience? Why did you feel that it was better to go about getting this referral versus another? That now really speaks to the experience and the expertise of the practicing physician, which is what I get to tap into and connect with, instead of just what I could have read in a book.
You guys pulled together contributors from dozens of med schools across the country. Are you outliers that you are the 10% of med students that are really aggressively using AI? Would you say these tools are widely used, or are you guys really some of the people that are kind of pushing the envelope here?
I wouldn't say that we're unique at all in using these tools. I think
Mm.
that maybe on a day to day, we're more focused on this question of how AI is going to impact our futures, and maybe, follow more people on LinkedIn that are talking about it. It might feel like we're in this conversation more, but every single medical student is at least using ChatGPT to prep for cases, to help them form presentations when they're rounding. Vast majority are doing that. I would say when it comes to the more specific tools, and maybe the tools that some people are using to build applications like Claude Code, that is a more specific group of people. And that's the type of people that we're working on this ebook. But the reason why we put together this ebook was to be able to reach those medical students that are really interested in learning more about how AI is impacting their medical specialty, but they just don't know where to start. So I would say that everybody has this interest, but not everybody is following the right sources to get that information, which is why we wanted to consolidate it all into one place.
Rishma, maybe can you tell me a little bit about what some of the key findings were from working on the book with Emily and working with the med students across the country?
I think the biggest thing that we can all speak to, all the authors can, is the enthusiasm, right? We have so much, not only just good enthusiasm, but we have so much good intent about what we want to do with AI in medicine. And I would say that it might be a misconception that we just want to put AI into everything, but it's really about where can we put AI that allows us as physicians and future physicians to be physicians, to be with patients and care for them and bring a lot of the reasons why we came into medicine back onto the table, right? How do we manage the admin work that was part of becoming a physician? Now that's part of our role. I think if you ask somebody who's not in medicine, what does a doctor do? They would say they give me medications or they tell me what my disease is. And a lot of us who came into this kind of wanted to be able to do a lot of that. But when you become a practicing physician, you realize there's all this other stuff that was part you didn't know was part of the job description. And, we do make a case for how AI has attempted or will attempt to play a part in a lot of those things and support your role as practicing physicians in the future. And that's really, we talk about not only just where it does work, but we also talk about where it has failed, and what our framework or what our hopes are in about how that could change and how it can pivot to make a difference in those fields as well. So this is across 9 specialties. So you can imagine the variation in how these tools can be implemented. And we're really excited for the readers to be able to connect with at least one, if not many, parts of what AI has been able to do or will do.
The next generation of physician innovators are already thinking hard about AI in clinical practice. Off-Call teamed up with MD Plus, a nonprofit community of physicians and med students across the country, to write the guide I wish existed when I started trying to make sense of all of this. It's called The Physician's Guide to AI, a practical primer across specialties. 9 specialties, 40 plus physicians, and it's completely free. Search for it now in the Kindle store or visit offcall.com. A quick word about today's sponsor, Evidently. Their platform turns an ocean of fragmented clinical data into concise, actionable insights. Chart summaries, note drafting, denial appeal support, HCC capture, so you spend time caring, not chasing. A transplant surgeon at a large academic medical center recently took transplant referral review from 2 hours to 20 minutes with AI-assisted chart review from Evidently. Physicians deserve workflows that improve accuracy, reduce exhausting chart biopsy, and help us practice at the top of our license. If you want to see how this might work in your hospital or your department, go to evidently.com. That's evidently.com to get started today. Emily, maybe I'll ask you, if a practicing physician picks up this book, but downloads this book and reads, one chapter, what do you want them to walk away from knowing that they didn't know before?
I want them to walk away with a better language to be able to speak about AI, as well as have a general understanding of the landscape of AI in their medical specialty. The reason why we created this book is because clinicians kept asking us those same questions about how AI is going to impact their field specifically, and there's just not a lot of consolidated information around that out there. I would say that a big conversation around of and around our peers is how AI is going to actually change the specialty that they might be going into, like reproductive endocrinology and infertility, for example. It used to be way more of a surgical subspecialty, and now with the massive success of assisted reproductive technology, they're not performing surgeries as often. So we really want to help medical students anticipate how these fields might change based on these new technologies so that they can make better informed decisions about what fields to go into. Also, by having a landscape of the AI tools that are being created in the fields, they can identify innovation areas that they want to work on in the future in those fields.
How do you think your attendings think of their med students using generative AI? Are they excited by it? Are they scared by it? Are they intimidated? Are they annoyed? For decades, med students have a certain level or type of question they ask. And, Rishma, like you said earlier, like you think you're asking better questions. So how is that received by the attendings that are maybe a little bit more challenged? Because the whole point of an attending is I know more than you.
So I think there are some things that they might not even know you're using AI for, like coming up with those better questions, like having a better presentation, like being able to reference an article when you're presenting on a patient. That all happens while you're pre-rounding on the patients, and you can just ask Claude or ChatGPT or Open Evidence, what is the best medication for this scenario? Whereas in the past, you would have to read an entire article to get that information. Now that information is just at your fingertips, and you're able to incorporate that into your differential and your assessment and plan much easier. So I think that level, they might not even be aware that we're using AI in that way, but it does benefit you and it benefits the patients. I would say there's definitely a general sentiment in medicine that people think that the younger generation, the way they're learning, is not as sophisticated as the way they were taught.
Yeah.
Like even something as recent as like step one going pass fail. I talked to a lot of residents who are like very annoyed at that. So I would say some people are on board with it, and they're really excited by incorporating the technology into their own practice and learning more about it from students. But then others are adamantly opposed to it and are afraid that it'll make medical students less able to do the tasks that now they are able to do.
Rishma, you just finished your medical ICU rotation, you said. I'm sure you interacted with lots of different attendings. What was your experience?
It's a range, but I think, you know, it's not just the attendings, it's also residents. They can also be resistant to it. And you would think that they're younger, they just came out, they're using it in their residency. Maybe they feel a little bit more. Yeah, they just used to, they understand me. But it can go either way. There are a few things happening here, which is the culture shift and the learning shift. The culture shift is you could say that the generation before the one of our attendings where people said, "Oh, we stayed on at the hospital 24/7. You should do the same thing." Now it's looking a little different, and they've added something else in that scenario for our generation of physicians that are coming out to the cohort. But I would argue that the role of every cohort of physicians and physician training is to have medicine evolve for the care of patients. So if your concern is related to how we are able to be better diagnosticians or better at assessing our patients, those are completely valid, right? But if your only concern with use of AI is, oh, you did it too quickly, then let's talk about what would you have wished that I would have learned instead. And that's kind of how I navigate a lot of those questions. There are attendings who have used it and do not enjoy what the output is. And in which case, I don't argue with it. I just ask, why do you think that it was a bad output, and what should I have considered that I didn't consider? I want you to, as my attending and my resident, to teach me how to critique an output because I don't want to fall prey to automation bias. And then there's, of course, those who use it and enjoy it. And with them, I kind of build a more collaborative approach. And I'll give you an example. There was a rotation I was on, and this was inpatient psych, and we were trying to manage their agitation. We couldn't figure out what to do. We had almost maximized all the doses that we could give. And we were concerned they had become a little bit more physical. I said, well, this is what I saw on Open Evidence. And my physician said, okay, great, let's put that order in. And I want to point out, I don't think that he just accepted my take because I think he definitely also knew what I was talking about. But I also want to add that it fell on me. And I'm really glad that I did this, where I still looked at what was referenced. I still looked at that paper before I made that recommendation. And so there's so much layer of understanding of AI, whether it's when to use it, disclosure, when to rely on it, when to critique it, and how to communicate it, whether it's to your physician or your patient. All of those are now newer skills that we're building. And so it's not to say that we're throwing out the skills that we need to have as future physicians, but it's also to say now we're adding more. And if you are an attending that doesn't use these tools, let's collaborate on how we can make sure that those skills don't go away.
I want to play devil's advocate a little bit because I've only gone through medical training once. I've only been alive once, as far as I know. My worry is that skills that I developed by, like Emily, to your point, by not knowing what to do or what was going on. And I was like, oh crap, I have some level of responsibility. I got to figure this out. But I guess when back in my day, when I was a med student a long time ago, say I saw something like Moya Moya disease in the past medical history. And I'm like, what the hell is that? What I would do is I would maybe have asked the intern or the resident, or I'd look it up. And because the tools I had access to were like up to date, I ended up having to read the full up to date article on Moya Moya. And so maybe I only wanted to know what it is. I didn't want to know the treatment. But because there wasn't a page on just the treatment of Moya Moya, there was just a page on Moya Moya, and I had to like dig through it. I ended up like learning more things about Moya Moya than I maybe wanted to. And I guess the way I think about it is med school is like for you to have a really broad drink from the fire hose, reading things through a more of a textbook format like an up-to-date or a systematic review article forces you to have a more global understanding of the disease process. I'm just like, I'm truly not trying to cast judgment. I'm just really curious how you guys see that future world. Do you view that as a problem or a challenge, or you're just fundamentally coming at it from a different approach?
Yeah, I definitely hear that sentiment. And actually, I feel like research needs to be done to explore how retention is different,
Sure.
like comparing people who will like read a chapter versus getting the direct answer to questions and being able to like interact with the LLM, ask follow-up questions. But I think this also speaks to a broader kind of question in medical training where I at least feel like my peers and I mostly have the best understanding of those diseases, medications, treatment plans, whatever, that are actually tested on in step one and step two, um, or the stuff that you see very commonly in the clinic. These kind of like one off things that aren't tested on and you don't see very frequently, I find fall out of memory really quickly. So maybe there's some tool in the future that can help with retention of the things that you see in the clinic. But for now, I do feel like most things that go into my memory are for step one, step two, and then everything else kind of post the board exams. I feel like you develop as an intuition in your training past undergraduate medical education.
I want to validate the concern there, right? Of how are we learning and what does that learning process look like? That resistance and that hardship of trying to understand something new is how our brain develops an understanding of something that is so vastly unknown to us. But it doesn't take away from a learner's mindset. And what I mean by that is when you were looking up that disease, you knew that it was something you didn't know and you knew where to go. And then when you read the first description, you were like, no, I need to know more. And you continued reading. You could have stopped at any point. You could have just looked it up on Google if you wanted and asked for a TLDR that I'm sure somebody would have given you. That is because you had curiosity into the disease and you wanted to make sure that you were covering all your bases for patient care. That sentiment, I would like to say, doesn't go away from the time that you're training. I myself want to have that. And so understanding when to use it, that's a skill set. How you're going to follow it up is another skill set. And I want more people to feel comfortable with having those conversations about, okay, if I am worried about one thing and I look that up, how should I navigate understanding what holds more relevance, right? And so I would say that, and I would highlight even further that patient care is still the North Star. So as long as we keep that in mind and we continue to nurture that, we will find ways in which we interact with our knowledge and medical knowledge base in a more, whether it's Socratic method or a more critical method in general. And that falls on having really good conversations with the faculty about it and having faculty be open about it as well. And this falls both ways.
I guess I feel like you can look at any generation and the younger generation is more reliant on some technology. It doesn't need to be computers or software, but it could be like my generation does more CAT scans probably than the last generation that did things more by Gestalt or, whatever it is. And so part of me totally understands that. And I wonder if that's how you two and other med students view this as like, look, this is going to be available. I'm going to be curious. I'm going to be patient centric and focused. And I think it's going to make me a better doctor. But yeah, I may rely on it more. But the word rely shouldn't be used in a negative connotation in that way.
Yeah, I think that relying on something is only bad if there is the possibility that it's not going to be there anymore. So this reminds me of on the last day of our OB-GYN rotation, the clerkship director taught us how to deliver a baby if you're in the middle of the subway, the electricity has gone out, like
Yeah.
you're in the middle of a snowstorm, like you can't get out and you have to deliver this baby. And I do feel
Love
like that's what like drew us all to medicine, to be able to um, be a practicing doctor no matter what kind of tools you have around you. So I do think that maybe we have to um, be okay with relying somewhat on the technology, but then also go back to ensuring that we know the basics to be able to act in situations when we don't have the technology. And like you said, be able to identify when the technology is leading us astray.
This is also speaking to if prior to AI or without AI, when your attendings and your faculty tell you, okay, how would you identify DKA if you didn't have the results back? Because your intervention's got to be a lot quicker, right? It's a bit like that, right? You still you're going to get those labs, you're going to order them, especially if you're in a really well-resourced institution, but you still got to know what the clinical implications are. You need to know to prioritize that patient maybe over another, or those orders need to be in a lot quicker. So that stratification is something that we learn when we get our hands dirty during rotation. I would add, and this is something that I reached out to my own faculty to ask about, because I had done my rotations and I said, okay, I understand medicine. I understand what to order. I understand what to give. But what do I do when the institution I'm a part of or the area I am in doesn't have access to any of this?
hmm
Because now I'm worried that my own medical knowledge is so dependent on results. And we talked about it, and I'll be going on a global health trip where 90% of those resources will not be available. And I know that in preparation for that, I should know my medicine, but I also know that in that scenario, in that area, I know I'm going to be tested. It's going to be whether I like it or not. I know that I'm not going to know things, and I'm going to meet my wall. And so, having those conversations with your students, with your peers, in a free setting, not just like in a classroom setting. It could be, the lunch lounge for all you care, and just being able to say, okay, that's your concern as training, and now this is my concern. This is what we're going to do so that your concerns are addressed. And so that collaborative approach, I think, can really help with a lot of the concerns that faculty and peers have in general.
Well, ladies, it's 2026. We're in an interesting transformational time. You guys will be attendings in, I don't know how long your PhD is going to be, Emily, but at
A
least,
little bit longer for
and,
me.
and you'll be at both attendings in, should we say, like 8 years? Emily, what do you think? 8 years? 10
Maybe.
years? Yeah. In 10 years' time, you're both attendings. What do you hope that medicine looks like? What are you doing all day? What's your job look like? Knowing what you know in 2026.
What drew me to medicine to begin with is that I love people and I love being able to feel that feeling of caring for someone. So my hope is that AI and these new tools bring us in that direction to be able to spend more time with patients, and to be able to have more opportunities to connect with them.
What has brought me to medicine is patience, right? I was working in tech. If I wanted to stay there, I wouldn't have gone into medicine. And so I am really excited for bringing a lot of the bedside connection that you have with patients, and making that a lot bigger part of being a physician, but also, improved patient outcomes, improved patient access. And I would say to anyone who says that as a physician, oh, I don't need to be a part of this part. Like, this is AI, this is tech, I don't need to be a part of it. And I would argue, and I would urge them to think about, if it's touching the patient, if it impacts the patient, then I think as a physician and a physician in training, it is our responsibility. we are the best advocates on this side of healthcare, on this side of medicine for the patient. And if we would do it for policy, if we would do it for, prior auth, if we would do it for any of those things, we should also do it for the tech that gets involved in healthcare. And so I'm really excited to see what happens as a result of physician involvement.
What makes you hopeful about where AI in medicine is headed?
What makes me hopeful is something I referenced before, the fact that AI and these AI tools can serve as an extra eye or pair of eyes on the patient. In the OB-GYN chapter of this book, we talk about all of these tools that are coming out for continuous monitoring of patients and for risk stratification of patients as well. I would say that medicine is it's very separated into the touch points that people are having with their clinicians. They see a doctor and then don't see them again for 3 months. So these continuous monitoring programs, like remote monitoring for maternal glycemic control, for postpartum depression, all of these things really have the opportunity for us as clinicians to be better caring for these patients when they're not in the clinic with us.
What I'm extremely excited about is that as this new wave of innovation with AI is happening, we're getting physicians involved a lot earlier. And that's what I really, really like, where I think for a long time, innovation in medicine was like implementing social media in a world of fax machines, right? Now, what I really want is not only for physicians to be involved, but for physicians not to be into picking a side. They can be objective and critical about what's happening. And they can be involved at the FDA level. They can be involved at the policy in their institution. They can be involved in building, whether it's within codes or with coding or not. They could be involved in how that is taught to their medical student. And so what I really like is the fact that we got on board a lot earlier for this wave than previously. We hope that we slow down to check all the nuts and bolts, but we don't compromise the pace at which we're able to improve patient care and physician workload. I also would say that the authorship of this book is another great way of understanding the joy of what AI can do and how people are getting involved and learning about it. But we also want the readers to know that these are not authors who feel only one way about AI. These are authors that have recognized its limits, have recognized its potential, and want all of you to feel the same way when you get involved, when you think about it, and have your own takeaways. And so I'm the most helpful because of not only how medical students are getting involved, how residents are being more vocal about what they want, but also how attendings are being critical. And so all of that together creates a really enriching environment of innovation.
My last question. Okay, it's 2036. You're both attendings. Think to the younger Rishma and Emily who are in med school. What does med school look like in 10 years for those versions of yourself? What's changed about medical training and learning?
What I'm hoping for is that these tools are being applied more and more to medical education and learning. I think this idea that LLMs can kind of help with the Socratic method is really cool. And I hope there are more studies validating that, and also studies on how to best engage learners and teach them through conversations with LLMs.
I am hoping just for the medical school component. If Emily and I are attendings, that means a lot of the authors are attendings. And so
That's right.
I'm guessing a lot of the students won't get the pushback from attendings of like, do you really need to use AI? But now it will be like, we would have seen how AI has been incorporated into teaching. So maybe every student gets an AI companion, and that's a tutor that helps their specific learning. And we're catching things a lot earlier. There is maybe within the EHR, we've created a place where, when you're on rotations, they say one of the best ways to learn is to look at the patients you've seen that day, study one concept. I'm really hoping that by then, that's what the education component looks like. We have, of course, advisors. We have every medical school, I would say, has advisors. You have your faculty. We have all of these people that are there but they're not always accessible. And so maybe for those individuals who are part of the student's learning, their time with with the student is quality of connecting with the student more than just providing the advice that you could have gotten from like a checklist or something like that. And so I think there's going to be a very dynamic way in which it becomes a part of learning and ensuring that we have wonderful physicians in the future. But I know that some of the resistance would look maybe different, and
Sure.
you'll have a lot of framework and policies in place, and a lot of the guardrails. And who knows, maybe by then we have the 10th edition of this book and they're writing it, right?
That's right. Well, you've both made me way more hopeful for the future of AI in medicine and the future generation of physicians. Emily Leventhal, Rishma Jeevan, thank you so much for being here on How I Doctor today. Thanks for joining me today. For interviews with physicians creating meaningful change, check out offcall.com/podcast. You can find How I Doctor on Apple, Spotify, or wherever you listen to podcasts. We'll have new episodes weekly. This has been and continues to be Dr. Graham Walker. Stay well, stay inspired, and practice with purpose.